So, well, first thing to say is that I'm really happy to be here with all of you. I have worked previously either using the technologies you build, the standards you build, and yeah, we from the government in Catalonia and Spain are, well, very grateful for all the job that you do. All of you represent either standards organizations, represent industry partners. You build technologies that foster at the end what Don was mentioning now in his speech, which is solutions that at the end benefit or should be benefiting the citizens, because everything we do, we do for them. And you know, it's strange, or it's a bit odd for them when they go into practice and all their information is not joined together or not pulled together, and this is something that they don't understand. So I would like to reflect with you how can we do better in order to join all this information. So as Don was explaining in his last example, clinicians, healthcare professionals have access to this data to deliver the best care as possible. So as far as for now, I think that we have advanced a lot into this matter, but maybe, well, there are more things that we can do from a standards perspective. So I don't know, any one of you who want to pick this, and we start discussing from here. I'm looking at Heather, but...
That's a big question.
That's a big question.
From my point of view, so as the newly appointed CCIO of openEHR, so I'm a clinician wondering how this was never on my bingo card to be sitting up in an international standards meeting. This is quite an extraordinary thing. But the clinical modelling for me is clearly my life. The breathing, sleeping kind of thing around how we design the data. And to me, the data is critical here. And how we describe the data, as well as how we move it around, how we store it, how we do the things we need to do, how we need to create, how we do smart stuff with it. So to me, data is core to all of these kinds of things. And I have been speaking around this for nearly 20 years about the little data. How do we get the little data right in systems? And so that is something that, you know, I'm wearing a t-shirt that's got fire on it because I'm going to be speaking about it later. We clearly need to be working very closely with SNOMED and other terminologies for this to work. But to me, all of this, the key is data, and I think that's where we need to start, and everything else basically flows from it. It's how do we reinvent our data standards, how do we reinvent our electronic health records that are data-focused, third generation EHR kind of notion, that are basically taking data out of the systems and so on. That's where my focus, I guess, and my priorities, that's why I think the starting point is, and I guess I'm curious where other people think that fits as well.
Yeah, if I may add to this, so I interpreted the question also a little bit like, okay, when I have friends or family or anyone sitting there and say, why can't I just have my data, right? Why aren't this stuff, isn't it cooperating? And I say to them, the things I say to them is, well, initially, you know, years ago, people would say, well, we can't exchange data because all these incompatible technologies and there's no way to exchange it. And I think this is no longer true. Whether it's openEHR or FHIR, we have the standards now. And then I said, you know, we've peeled off this layer of excuses. No, we have the technology. We have technology to exchange everything. We have the infrastructure everywhere. And then I wondered whether it was like regulation, but we also know there's a lot of new regulation to stimulate this. There's in the US is actively stimulating, you know, trying to avoid blocking of data, and still it happens. So if you peel that layer off again, you see that it's also because of well, I'd say habits, fear, and market forces that also stop us from being able to exchange the data like our friends would like to. And we can definitely cooperate because we're all facing those same forces. So this is, I also think, where we should cooperate.
Yeah, thank you. If I may, spot on, because looking back at the last 20 years of openEHR, I see a lot of effort, but at some point you take a step back and you realize that what we have been doing at some level goes against the core principle of a free market economy, where what a vendor has to do is to create a network effect. And what we're doing is, with the help of regulation, trying to set the balance so that, you know, the market keeps functioning, we have the vendors and the system works, but at the same time patients get the best they can. Or at least that's the idea. But I think really genuinely what's next for us as the standards communities is what I'm going to advocate definitely in whatever role I have in openEHR is just to stop, take a step back, and instead of asking the question, ooh, how can we do what they're doing better, asking the question, okay, what can we reuse from what they have done? And this has already been happening, and because if we don't collaborate, and you know, you made a great point about it, if we try to just replicate or try to, you know, get into a race of improving upon some work that's already done and, you know, accepted and working in another standard, we're just losing very precious time. And the big problem is we're failing to provide immediate value. So if whatever you're trying to do exceeds the lifetime of a government, of a program, of whatever allocated budget or official you have, then before you can show the benefits, the curtain goes down and someone says, yeah, that didn't work. So I, for one, I just don't understand, if we're all trying to eliminate silos of data, why on earth are we creating silos of communities in the standard space? That's just such an opposite of what we'd say we're trying to do. So for me, genuinely, the next step is to try to reuse and work with what already exists and have a different view about it.
I think it's a very good what you say. It's exactly like this. The silos of the communities, and you know, I think there's not so many, like tens of thousands of people sharing the same philosophy. And I think what we do is we do share basically the same philosophy. We're coming from different angles. We have different aspects. So our technologies have been, you know, are addressing different aspects. But at the end, we have the same vision of where the healthcare systems of the world should be moved into. And this is something, there's a reason why representatives, protagonists of HL7 Fire and SNOMED and other initiatives are here at the conference. That's exactly what we want to do, is you know, share something, and how can we build, how can we change, how can we impose this change to the healthcare systems of the world? You know, cooperating, taking advantage of synergies that we all have to bring to the table, and everybody can focus on what they can do best. And it's always the two things. It's, you know, it's technology, but it's also, you know, governance. How can we take care that, you know, we really provide the best data at a quality level that ensures that, you know, it sets the foundation basically of, you know, providing AI for healthcare. And data is, you know, that has been said several times, data is the fluid, that's the oil of the 21st century. So this is what we need to take care that this is being done in a joint effort.
You want to add something?
Yeah, I was just thinking, in terms of an email that I had a couple of weeks ago, there was a doctor in Kenya who sent an email to an email list that I was involved in, and he said, we've got an outbreak of monkeypox in Africa at the moment, and is there anything that anyone can share with us that we might be able to reuse? So thinking data-wise rather than application. And speaking with the Ministry of Health with Jamaica that we've been working with, we'd built a monkeypox data set last year. And they said, yep, please share it. We're really happy. This is global public good. And so I went back to this doctor and I said, we have this data set that we've developed. It's been standardised along with a whole lot of other diseases across Jamaica. And you're welcome to use this. And he said, no. He said, every country in the world has just created their own data set for monkeypox. Every single country. And they will be for the same disease, with the same symptoms, the same kind of treatments, the same kind of principles, but they will all be slightly different. And that is amplified all the more because in this Jamaican work, everyone has built their forms, paper forms, by themselves in splendid isolation. So whether this is just a data project, whether this is an application, whether this is a national project, everyone just works in silos and they all do their best. But what we found was when we looked across 12 diseases, there were 9 different ways of saying they were dead. So something as simple as alive or dead with a date of birth was done differently, and there was no way that any of that would be interoperable. And so we had to decide at national level, how do we describe that somebody is dead? And I think that, you know, whether that translates across all of our data, everywhere, globally, how do we report that at national level? How do we report it across a regional level? How do we report it back to WHO? When you kind of think in those terms, it's kind of scary about the data and the amount of data that's being created at the same time. If we start to change the way we think, so it's not looking down, this is our project, we've got to do it fast, we've got to do it quick, we've got to do it our way because we're special and our data is special. If we start to think differently, we start to change the way we do things.
Well, I agree. I think the one thing that I've seen is variability kills any type of data integrity or interoperability. In my home province of 1 million people, they have 14 regions, and each region has a lab test that is called something different, and yet it's the same lab test. It's no different than in the old days when somebody bought a Meditech system. The hospital down the road had to buy a Cerner system because they were different and they wanted to one-up them. And I think we've got to get away from variability and also away from consensus. I think we've got to have, from a community perspective, I'm talking all standards, we need to go with the majority, and some people won't be happy, but they have to be absolute. I think that's the first thing we do. The second thing that somewhat worries me is there's a lot of focus on data, and people are blindly going back 30 and 40 years to mine data, and most of it is not relevant. And I look at my own health record, and they're putting together the summary record, and they wanted to, you know, digitize my record. The 15 knee operations I had, they're not relevant. The symptoms that come after as you age, arthritis and deterioration of joints, they're relevant. But coding those surgeries, they're not relevant. And I think we as standards organizations have a duty to advise governments that going back to all of those paper records that are in various healthcare settings and coding it all is wrong. We need to start to say, here is the minimum data set that we need out of those records in order for researchers and clinicians to actually take a look at trends from the past and make decisions for the future. And the last thing that nobody really talks about is the clinicians. They have tough jobs. They care about their patients. They have to deal with regulations. They have to deal with paper. They've had to deal with digital records. And in this day and age, I find it amazing that the EMRs in both hospitals or the EHRs, when they go to do something and they need a code, they have a drop-down box. And it could have 50 items on it, and they've got to take time to scroll to find the right code. In this day and age with artificial intelligence, which I agree we should embrace and become really the underpinnings of artificial intelligence, all our standards organizations can be underpinnings for it. That with artificial intelligence, you should have something that when you tell the clinician you have a chest pain and he writes that in, artificial intelligence says, here are the 3 codes that are applicable, which one do you want? 99% accurate, 95, and let the doctor pick the code. Saves time, it saves money, and it saves burnout from the clinician level.
I think this is very interesting, time to be doing standards-based work, because I don't think many of us are going to see a situation like this where a massive wave of funding is coming towards everything, which is AI at the moment, as long as you can find a way to leverage that. And actually just having gone through the whole process of AI and decision support and EHRs, and I was privileged to just do the PhD under David Ingram. Looking back, I think this new generation of AI actually, it may offer opportunities for us in the most unexpected ways. So the problem I see with clinicians and standards is, as I said, we're not really capable of offering an immediate value to a clinician. What you said, yes, that helps. I don't disagree. But our problem is when we try to get more clinicians, for example, involved in, just CKM and Ocean and Sebastian, they do their best and the team tries to put as many features. But the problem is when you have really busy, overworked, exhausted clinicians who would ideally like to take part in what Heather is leading, then that gap, that learning curve between the standards and their volume and everything we're putting in them is becoming a problem. So we need to find a way of, just the complexity of the problem shouldn't automatically create a complexity of the solution. And I think AI is something that can help us eliminate that. So, just, yes, making decisions, all sorts of advanced things, when clinicians use them, that's fine. But I think I'm very interested in taking the knowledge and everything we've been building and making it easier for clinicians to contribute, to ease the learning curve, to make it easier for them to grasp, a lot of knowledge that they need to conquer to be able to contribute back. And I think this particular generation of AI is going to have very unexpected uses if we try to apply it to that problem. And I think it may also be the thing that finally gets us through those doors in the governments, because it's a very unusual situation where you can say that, just let's get more clinicians involved, but we can do it easier this time. I don't know where to begin, working on that, but that's a conversation that needs to, I think, take place over some coffee between standards and see how we can do it. But I think it's a very interesting opportunity there.
We are in this hype phase of AI, and it's everywhere.
Yeah.
You will find in every other project, if you don't add AI, you will never win the project. But are we really training this AI on the right data? All these algorithms, all this AI that we train, is it really portable to somewhere else? I mean, when I train this AI, whatever, on top of my EMR data, when I move this from Epic to Cerner, or from Cerner to Allscripts or Chipsoft whatsoever, will it perform the same? Because if we are missing this shot here, well, it's an opportunity that is lost. And clinicians, they fear such, not all of them, but some of them fear such technologies. And I mean, we are working in a sector which needs to be evidence-based, and well, missing the shot in here, it's a problem. What do you think on this?
Yeah, I've been wondering about the same thing, like what should standards organizations, how should we change? What should we do to our standards to help AI perform better? Because you were already talking about doctors selecting codes. A lot of the work of getting data or extracting useful information on a body of data is selecting codes, classifying stuff. And our AIs should be able to learn how to select the right codes and the right things. I think, of course, they can extract probably the main diagnosis and so on, and names and birth dates. I believe so. But a lot of things we do is classifying things when we're extracting data. Now, and if you look at our current standards, most of the time what's happening is that our value sets are documented code by code with 1 or 2 lines. And human beings are supposed to read that and know how to, which codes to select. And if we don't know what, we ask our colleague who's been doing this for a few more years, or we ask the author, what should we do? Now, I'm wondering if we really want these AIs to be, extracting the right codes here, should we as a standards organization change the way we specify our code? Should we provide learning data with, if you encounter this, then you should select this code? Is that what we should do? I don't have an answer here, but I think these kind of changes is what we should be looking at.
I don't want to put too much water into the wine here. Of course, we need to talk about AI, and AI is the hot thing. But I think we're one step before that, actually, in the real world, because we're still struggling to get the data out of the silos right now, and having one point of data truth. Where the data is being consolidated. So we are still in this sectoral thinking in the care side, where a patient is coming into the hospital and the history is simply not available, and nobody knows what was before. So I think this is the reality that we need to tackle, and then automatically we will have the foundation basically where a good AI can be based on. So I think we have a lot of discussions with our CIOs or CDOs from hospitals, where they say, okay, yeah, clinical data repository. So what you do is basically, okay, CDR, clinical data repository. I understand that. So this is you're harmonizing basically the 20% of the data that is already structured or semi-structured available. What can I do with the 80% that is unstructured? So I think this is the reality, and we have to find solutions basically for that, how to actually, get an evolutionary step of having really, possibilities to access the data, to then harmonize the data, keep it consistent, and then basically put AI on top, which I think is the next evolutionary step then.
I think, I think you're absolutely right, and I think Ewout made a very good and valid point in the sense that we have become crazy asking our clinicians to be classifying things and wasting a lot of time that, interacting with the computers instead of touching the patients. And maybe, I don't know, the next step would be, allowing them to care for the patients, and while they speak with the patients, allow some sort of machine listening, I don't know, I say Alexa-like, listening in the background and then making the things in the right boxes. Possibly that's one of the main features of the 3rd generation EHR that Heather was mentioning, because we very often forget about healthcare practitioners, and they have devoted vast amounts of efforts in coding and collecting all this data. And if we let them know, and now clinicians in the room, you don't listen to this, most of the things that they collect is worth nothing, and we don't use it. That's my thinking.
I think we need to recognise there are different types of AI, and we can't just use this blob is AI. And so, we can, I think, probably travel very fast with some process-related things that are not clinically significant, if you like. But the other extreme is where you've got data that needs to be very precise. If we're going to start doing decision-making, automated decision-making, precision medicine decisions, all of these kinds of things, we need to make sure that our data is very, very accurate, very well defined, and we have algorithms that are tested and safe. So we need clinical governance across all of these kinds of things too. So there are some things that we can go fast and loose with, some things we're going to have to be extremely careful about.
I would agree with that. And I think, again, the way I look at it is we can look at AI and say, we got to be careful with it, or we actually insert ourselves in the process and become the foundations for a large language model for some of these AIs. I'm not suggesting they do clinical decision support, but I do think, like everything else, it needs to learn, and it should learn from the standards how to code the data, how to collate the non-structured data, which saves time and money. Obviously, you still need people to quality assure to make sure that the data coming out is fit for purpose. But at the same time, it's a useful tool going forward. In our organization, we have an AI strategy. We are now using AI to determine whether or not we can translate all of our codes into different languages, and we're quality assuring that and teaching it how to do it. We're also starting it to look at content development and quality assuring that. So baby steps, but if we don't get engaged with the private sector and the artificial intelligence areas that are working on that in healthcare and in large language models, who are governments going to believe? Because we've been here for decades, and where are we now? And governments are looking for quick wins to move things forward at lower cost. So I just caution, we have to embrace them carefully, but there are some good things that can come out of it.
Yeah, that's also a very good point, and I also wanted to go to the data governance part, or to the information models governance part, if you want. We, as you know, in openEHR have a very long-standing repository, open one, with all these information models. I will use Spain as an example, also has its own repository of information models, which is valid for the 17 regions that conform Spain. And building on this minimal data set that you were mentioning before, Don, we establish our semantic interoperability. And now, initially this was a summary of the information, and now we are advancing towards more granular information to be shared across all these different boundaries. And well, one characteristic of this is the openness of these information models. So all the ecosystem needs to be aware, and tools such as the CKM help to do this. So the use of open standards, it's an important one. Governments committing to the standards, it's also an important one. Spain is member of SNOMED, is member of openEHR. They actively map things towards FHIR. Same movements we are seeing in Australia, I believe, with the project that Heather is carrying the t-shirt very proudly. So how do we convince these governments that Don was mentioning? They have short-term quick wins. I mean, they stay in there for 2 years, 3 years, 4 years. They want shiny things, and then they leave. And they want, I use the example, they want electric cars running in roads that are not prepared for electric cars. So how do we tell them, listen guys, you need to stop, we need to rethink how we build this infrastructure, or this infrastructure, maybe, if you want, using Heather's words.
Yeah, I think it all comes down to, again, David's words, implementation, implementation, implementation. When you have different standards communities with their strengths and their experiences, I think whatever real life delivery we can put together, you know, something, it was a very unfortunate situation, but for example, I think all the standards represented here did a fantastic job during COVID. SNOMED CT came up with the codes, fire, openEHR, all the models and the systems responded in the best way they can. That was an absolute tour de force, showing that, look what this can do. So I think we need to just, and that's the thing, just one of the conversations I always keep having in Ocean is, can we extend the community in the CKM? Can we, just bring developers or even policymakers somehow and connect them to what you're putting there and show how it comes together with the fire mappings and OMOP mappings? And that's the kind of, just working together that I have in mind when you take a step back and bring the best of everything together, but we have to connect it to some actual deliverable. And that should be the result of, just a conversation between these groups. What is it that would prove our point to the governments in the shortest term so that we actually get support for working this way together? And I don't have an answer to that, but I'm more than happy to have the conversation.
Don't have the answer.
So I guess from my perspective, there's two things you have to do. And what we did in order to get government's attention was we built an economic tool where they could plug in all the health data points within their country, EHRs, EMRs, public health, et cetera. And we had economists build this tool so it would show them how much they saved if they had structured data. That's something that a politician can look at and go,
yeah,
oh, I'm going to save this much money. I'm going to go spend that on something else. That's their job. But our job is to show them the savings. But I think if you want a living, breathing example, it's the IPS. Mm-hmm. It is probably the first use case that I've seen in almost 40 years, other than maybe what happened during the pandemic, where people are actually excited. They can see the scope of it, they can see all the standards working together, and they can implement it rather quickly. And eventually, when you start, if there's no variability within the IPS that's in my record, if I go to another country, you can be treated, they can see your relevant information. It's not a lot of information, but it's relevant. And if you need drugs, you can get a short supply from a pharmacy, you can get to see a doctor and they know all of your symptoms. But more importantly, if you get hit by a bus after having a few pints of beer, like I might, then they know that you're not allergic to some of the drugs they're going to give you because I'm unconscious. Mm-hmm. So at least they have the relevant information. I think that's the starting point. Mm-hmm. And if you're talking to governments, in my country, the interoperability roadmap in Canada specifies that everything's to be done as it relates to the International Patient Summary. And that's a good starting point.
I've been advised that we need to finish.
I didn't see any hands.
I'm really sorry. I also had another important question for you, but I've been advised that we made our time. So please join me to thank our panelists in this conversation.